I could actually talk for this entire time about her career, and I'm not going to do that so we can give her the full time here. So I'll just give a few highlights and then I'm going to add to them a little bit. But Marya Gwadz is Associate Dean for Research, Professor and Director of the Intervention Innovations Team Lab, IIT Lab at NYU, Silver. She also serves as an associate director in the Transdisciplinary Research Methods Core in the NIDA-funded Center for Drug Use and HIV Research, otherwise known as CEDAR, at NYU School of Global Public Health. She has been the mentor and now collaborator of one of our star postdoctoral fellows here at the HIV Center, Sabrina Kluisman. And Sabrina, I almost called on you to do this introduction, but did not. But thank you for bringing Sabrina to us. I've actually, in addition to knowing Dr. Gwadz from our early days, you were on our DSMB for a little while for the HIV Center, and we sat on study section together. And because our work has interfaced in terms of the focus for youth, I've gotten to watch the incredible work that you've done. Um, and just to give you some highlights, she has been cited over 7,500 times in the literature in her work, and since 2020, almost 3,000, I think, with a large number of publications. I didn't sit here and count them, but they're incredibly impressive. Her work has continued to focus on vulnerable youth, but she's also looked at things like the development and evaluation of potent, innovative, and culturally salient social behavioral interventions to address racial, ethnic, socioeconomic, and gender inequity in health. She's worked, as I said, with vulnerable adolescents and adult populations, spans 3 decades, and focuses on populations such as persons with substance use problems, sexual and gender minorities, heterosexuals in high-risk contexts, populations with high rates of criminal justice involvement, runaway homeless youth, and people of color living with HIV from low socioeconomic status backgrounds. So she has continued to fight the fight for those who are really most vulnerable to HIV and to all of the health disparities that are out there. Dr. Gwazd's program of research has been continually funded by the NIH since 2000. She's an expert on the multi-phase optimization strategy, or MOST, a framework for developing efficient and cost-effective interventions with no inactive, poorly performing, or counterproductive elements. So I could go on and on about her grants and her papers, but I'm not going to really do that other than to say I'm a fan and have been watching your work for a long time. And it was a pleasure to stand up for science with you recently, relatively recently. And so with that, I'm going to turn it over to you.
Well, that was wonderful, and thank you. And I have so many wonderful memories of the HIV Center. My first job when I entered grad school was at the HIV Center. And do you know, as you get older, sort of your memories of your earlier days actually are more clear than yesterday. And I have so many great memories. Like the old timers remember meeting with Rhoda Gruen every 2 weeks to make sure you're measuring sexual behavior comprehensively. And
Totally.
me, little interviewer. So that I was saying before we joined all of you that I can't imagine my life without the HIV Center. It was completely transformative and put me on a path to do this work that I love so much. I really consider it an honor and a vocation to be involved with it. So with that, let's jump in. So today we'll do two things. I'll give you a brief introduction to the MOST framework. You may be very familiar with it, maybe you're not. Hopefully what I say is it's not too long, so if you do know the MOST framework, it shouldn't be too boring. And then I'll talk about an application of the framework with people living with HIV with non-suppressed HIV viral load. So we all know that HIV travels on the fault lines of society, and the inequities in HIV are very serious and persistent, and they're also intersectional. So we have racial ethnic disparities, socioeconomic status, sexual minority and gender minority disparities. Substance use is a huge role younger people struggle along the HIV care continuum, and then we have geographical differences. So this is a snapshot of sustained viral suppression by race ethnicity, which is a very useful graphic. You can see that it's hard for anyone. It's overall, we have half of people living with HIV who sustain it over a long period of time. They stop and start, basically. And people of color have greater barriers to sustained viral suppression. So our work focuses here in the yellow. We focus on people who are not sustaining viral suppression, who are not taking medication necessarily on a consistent basis. Um, but we have situation. We have a life-threatening condition, and we're grateful to have life-saving medication that's tolerable and incredibly effective. And actually seeing the medications change over the decades has been an absolute credit to science and so exciting. It was bad before protease inhibitors. It was very hard in the beginning, and now the medications are amazing. Um, so in our field, we have progress. Oh, and but then time passes and we have big events, which is one of the themes of our NIDA funded center. Big events could be wars, economic downturns, uh, political administrations that are more or less supportive of HIV programs and research. We have people aging in and out of risk categories, and then we have innovations. We have technology innovations and innovations in our field. So continuous innovation is a norm in most fields. I don't know if anyone recognizes this. This is the first Mac desktop. It came out in 1984. It had no hard drive. My school, University of Rochester, was actually a beta test site for this machine. I used this machine, and we were so excited to have it. But what if they hadn't ever innovated or changed? But in fact, they have. So now in 2025, 26, you could get a watch that has a million times more computing power and hard drive space and everything else. And you couldn't even imagine. But intervention science really did not innovate that much beyond the RCT for decades. So I'd say that the intervention science, and we'll think of the classical approach where a packaged or multi-component intervention is tested against a control, has challenges in three main areas. So first of all, our interventions, and I'm going to say my interventions, I'm certainly guilty of this, are generally long and complex. And that's because our goal is to show effects. And I think that, and Linda Collins, who is the original developer of the MOST framework, pointed this out to me, probably not consciously, but unconsciously, we pack our interventions with components because we have a million great ideas. There's so much that can be helpful. We want to be useful, and we also want our interventions to show effects to work. So we may pack our interventions with multiple components. But these long and complex interventions can be challenging and expensive to implement. And if clinical settings implement them, which they do, including through the CDC DEBI program, they may modify the interventions, but they don't have any guidance really on how to do that. Second area of concerns is that if our packaged interventions work, we don't know which components were active. If they don't work, we don't know if there's anything that was worth keeping or what next steps in our program of research should be. And then if the settings do modify the interventions, as I mentioned before, they could actually eliminate the active ingredients and keep the inactive ingredients because there's really no way to know. And then we don't have much precision in understanding how interventions work. Then the third area of concern is that we know that there's 17 years between an RCT demonstrating effects and implementation of an intervention in clinical settings, and NIH has been aggressively addressing this problem for years, but it does remain a problem. So the MOST framework is designed to address these three sets of problems. So here's a graphic sort of describing the MOST framework. So instead of the classical treatment approach where you package components, test it in an intervention, and then you evaluate it in a RCT. And that's Linda Collins's animation, just so you know. I don't know how to do it crunched up in animation. In the MOST framework, you test separate components in an optimization RCT. Then you put them together in an optimized intervention, and then you can evaluate it in the RCT. So in terms of what's a component, I think it's important to know a component is any aspect of an intervention that can be separated out for study. It could be really large. It could be really small. It could be an implementation strategy. It could be a prize. It could be an electronic health record, a pharmacy flagging system, a pamphlet, a counseling program. That would be considered a big component. It could be an AI-driven component. That's a new field. Peer mentorship, text messages, could be a medication, could be a video, an app, could be something existing, something new. So what is intervention optimization? It's a strategic balance of four things: effectiveness, so the components work, efficiency, economy, and scalability. So we talked about problem 3 as this long lag until implementation. And the MOST framework has scalability at the start. So the framework has 3 phases: preparation, optimization, and then depending on what you find in your optimization trial, you can move to an evaluation phase where you confirm the intervention in RCT, or you can go back to earlier phases. And I'm going to talk to you about a program of research that spans the preparation and the optimization phases. So in the preparation phase, the goals are to create a conceptual model, identify a set of candidate components, and then identify an optimization objective. What do you want this intervention to do ultimately? So here's some examples of optimization objectives. And you can see that they have scalability and economy and efficiency at their core. So you could create the best intervention to be carried out in a certain number of hours. Say a clinic has a 5-hour program that's funded. You could create the best intervention that be carried out in 5 hours. The best intervention for how many dollars? $1,000. The best, most scalable intervention for a certain setting, or the most value efficient intervention with respect to cost, which is similar to cost effectiveness, or the best intervention with no inactive or counterproductive ingredients. All right, so let's turn to the problem that we address. So our interest is insufficient rates of engagement along the HIV care continuum, and we focus on African American and Black and Latina people living with HIV because that is where the disparities are. So we go where the disparities are. If the disparities were somewhere else, we would go somewhere else, but these are the disparities for reasons we'll talk about, and that is what we focus on, the orange bars. So let's talk about our preparation phase. So, I've already told you what the goals of the preparation phase are. There's different ways to handle it. I'll tell you about how we handled it. So we had an R34 funded by NIMH. And we focused on Black and Latino adults living with HIV not taking medication at enrollment. It's 95, normal sample size for an R34, and they were recruited mainly in the community. We found they were difficult to locate in clinics. They don't present so often in clinics. So our design pilot RCT, and then the intervention was grounded in a conceptual model I'm going to tell you about, developed by our team. We call it the IT Lab Integrated Conceptual Model, or ICM, and had multiple level targets of behavior change, very heavily focused in motivational interviewing, and designed to be culturally responsive and structurally salient. And I'll talk a little bit more about that. And our outcomes were biomarkers. We had adherence tested in hair samples and HIV viral load tested, examined by lab reports. So in terms of designing the intervention's key elements and core characteristics, this is the ICM model that we developed as a team and came about actually over about 10 years of work. And if you look at our citations, you can see Dr. Klusman is heavily involved in this work and absolutely central to this work. And these papers are very interesting. If you have time, I can send them to you or you can find them yourselves. But the ICM integrates critical race theory where we center the margins, which means we center the experiences of Black and Latina people living with HIV, really try to uncover counter narratives, resistance and resilience, historical factors that cause the problem that we're talking about, systemic inequalities, and systemic racism. And then we bring in harm reduction, which is very pragmatic and emphasizes no preconditions for treatment. So how that might look on the ground is we have an intervention for people living with HIV who are not taking medication. We don't necessarily assume that they will take it, that they're ready to take it, that they want to take it, and that is not a precondition to be engaged in our interventions. It values any positive change and it's non-coercive. So harm reduction is usually applied to substance use behavior, but it can be applied to any health behavior. So we've applied it to our HIV work. And then self-determination theory down here is the third theory, which emphasizes autonomy, competence, and relatedness. And autonomy is very important in this work because people, especially in low socioeconomic conditions, have very restricted autonomy, and they're very sensitive to that. It's a serious problem. And then here is sort of what like the emergent properties of the integration of these three existing theories. So structurally salient means basically that we attend to the structural realities of people's lives. Culturally salient is like cultural competence, but we seek to earn trust. We don't assume that we have it. We try to build trust and reduce stigma. The theory naturally aligns with motivational interviewing and the theory of triadic influence. And we hope that it promotes social justice. So in terms of like where we start, so the problem, people not taking medication, we start with in the model, which actually I would say the model has step-by-step instructions about how to use it, and it does relate to other models of like the intervention development. We hope that it's helpful to people. But so we start with like why things are the way they are. So this is a root. So these are like the root causes of the problem from our qualitative and quantitative research. But one of the root causes is historic and present day structural racism, exclusion, and bias. This contributes to medical distrust, fear of medication, and disclosure concerns, and then competing priorities related to poverty, including mental health concerns and substance use problems. But we also have at the structural level unstable housing, but not just unstable housing, sometimes a real mismatch between the needs of the person and the type of housing that they get. And this is a little like maybe like a little strange to think about because housing people is great and HASA is amazing. And we're a very resource rich environment, and that's great. But people don't always get the kind of housing they need. Some people really benefit from supervised settings like SROs. And for other people, it's absolutely devastating for them to have no autonomy, no kitchen, live in a chaotic environment and to be supervised. It's also hard for people to access ancillary care for substance use and mental health concerns. We do have integrated care settings, but they're still not fully resourced. So at the same time, barriers and with the barriers, the strengths co-occur. Everyone wants good health. Never met anyone who didn't want good health. And there's a lot of resilience, activism, and advocacy, and altruism, and also willingness to take antiretroviral therapy. One thing that I've seen throughout my career is that people might have concerns about antiretroviral therapy and not be taking it or not want to take it, but they also are willing at the same time to take it. So there's just a lot of ambivalence in that domain. So here's what our intervention looked like grounded in the ICM. And I'd say it's pretty typical intervention components. So we had intervention sessions with individuals, and we had some videos to kind of prompt the discussion of some of these themes that we're interested in about distrust and structural factors. We had a support partner be involved in the sessions to support the person with their ongoing adherence if they decided to take medication. We had support groups co-led by a successful peer who's virally suppressed and a staff person, and then patient navigation, which tried to do a lot of things, connect to providers if they needed that. Most people were engaged in HIV care settings. We support that. We don't disrupt that. Referrals, and then talk to them about sort of adherence. Our outcomes were acceptability and feasibility, consistent with the R34 mechanism. And then we also had our biomarker endpoints. So we had ART initiation, we had adherence tested by hair, and then our primary outcome was viral suppression. So in terms of evidence of efficacy, it wasn't powered for efficacy, but we did find substantial effects. We had medium effect sizes at statistically significant levels. And so you can see here that in the intervention arm, tenofovir concentrations in hair were higher than in the control arm, and everyone was on a tenofovir-based regimen. And then in this second part, most people were taking medication, and you can see that HIV viral load is much lower in the intervention arm than in the control arm. So actually I was really excited about, when I forgot the first, so we send the hair in like tin foil, and then when I got the first Excel spreadsheet back, it was from Dr. Gandhi at UCSF. I could not believe what I was seeing. It really did work quite well. So although we had these effects and they liked it and it was feasible, the intervention was kind of typical and they had a lot of components. It was not super hard to implement, but it wasn't super easy to implement. But it's, typical intervention that was fairly labor intensive. We see that the components had some components, and when I look at the navigation component, I see it's pretty packed. So I'm guilty of what Linda Collins has raised with me, is that we want it to work, so we do pack with components. It was quite a diffuse component. And so we knew that we didn't know what worked. Were all equally effective? If some were not at all effective, or if some had counterproductive effects. When I was first told that components had counterproductive effects, I was like, that doesn't happen. But anyway, that's cute if you have that idea, but that never happens. But now actually we've done, I think, 4 optimization trials, and 2 of them have had antagonistic interactions. So it does happen. All right, so then we moved to the optimization phase. And Dr. Collins and I are MPIs funded by NIDA. And so the first study was called Heart to Heart, sort of a play on heart, highly active antiretroviral therapy. And now we did Heart to Heart, now we have Heart to Heart 2. No pressure, no judgment is our tagline, hoping that from the second people hear about us, they get a sense of our ethos, which is grounded in the ICM. Optimization. So in the framework, there's a lot of designs in the framework. The framework, most is not a design, most is a framework. So within the optimization phase, you can do factorial experiments, fractional factorial, smart designs, which are to develop adaptive interventions, micro-randomized trials, which are mainly for, online or internet interventions, and then other. So how did we move from the preparation phase to the optimization phase? There's different ways to do it. So we tested our package intervention as a whole. We got our results, which I've just presented to you. And then an intervention working group derived the candidate components from the packaged intervention, created a conceptual model, and developed an optimization objective. You could start the R34 stage or the pilot stage testing intervention components. That's getting more common now. And if I were to do this study again, that's what I would do. I would start with a pilot optimization trial instead of testing a packaged intervention. But I think testing package is fine too. So here's our conceptual model, and where you would want to start would be the main addressable barriers. And these are your mediators. And really, you can cut this up different ways. It's grounded in your theory, how you see the world, what you think is important. And you can move things around and, pick the mediators from the literature and your own work that you think are the most important. So for us, we broke them up in this way. So we have health beliefs and emotions. So health beliefs would be like self-efficacy and outcome expectancies. Um, and motivation. Behavioral skills was mainly habit formation. We had peer models and norms are important. Social support and stigma were important, and then structural barriers to health. Then you map the components onto the mediators. So we have this is a very counseling heavy intervention. I told you before, components can be anything. It's a tough problem to address. And so we went for this counseling approach, but it does make this more labor intensive than other optimization trials that you might do. So we had, I'll tell you a little bit more about the components in a second. These are components. So our goal for the model were that the components need to stand alone. Um, they're not dependent on any other component to make sense or be useful to people. They're consistent with the theories guiding the study. And then our decision was to make them comprehensive with respect to levels of influence. We wanted to address the individual, social, and structural levels of influence across the different components. I would say conceptual models for intervention research is hard. It's hard because you really can't present every relationship and you can't really present bidirectional relationships. And it's a real struggle, I think, for all of us, but they're much, much easier in the most framework compared to the classical approach. And they're also more precise. And this aligns with NIMH's interest in experimental therapeutics, how things work, because you will be able to look at how things work. And in terms of your model, you might be wrong, you might be right, but at least you'll get a sense of what mediator the components speak to, if any. All right, so here are components. I won't go through this in detail, but you can see, first of all, there's a core intervention that everyone gets. It should be the standard of care. We don't test it because everyone gets it. And we did health education in a single session, but we also started to communicate the ethos of the study, which is this no pressure, no judgment. People would come in and say, do I need to take medication to be in your study? And actually, everyone from the work study on up was trained in the model to say, it's your decision, obviously. I mean, obviously, it's their decision. They can take it or not, whether they want. So we're just stating the obvious. But we're asking if you want to have a conversation about this. And if you don't, that's fine. And if you do, that's fine. But really respecting someone's autonomy. And I will say might sound a little strange, but this is over like 20 years of work. People will say, I've never been asked if I wanted to take medication before. I mean, and I can understand that because as we said before, we have a life-threatening condition, we have a life-saving medication, two great things that go great together. It seems obvious that you would want it. I mean, I would take it if I had HIV, definitely. And I'd be grateful for it, even though, it's emotionally taxing and, it's not a walk in the park, obviously. And there's toxicity associated with medications, there's also toxicity associated with living with HIV. But that question isn't really entertained. So if we have motivational interviewing was 4 sessions. The pre-adherence skill building, which is the habit formation, was 4 months in duration. Peer mentorship was 4 months. Support groups, we had 6 groups, and then we tried to make the groups complementary to healthcare settings. So you could talk about things that are a little hard to talk about in clinical settings. For example, substance use is hard to talk about because they know they shouldn't be taking substances on antiretroviral therapy. They could talk about medical distrust. They could talk about not taking medication. And then we had navigation. The navigation was typical navigation model, except grounded in the ICM, where there's like an acknowledgement that we don't assume that people want to take medication or are ready to take medication. All right, I said all this. And then the fun fact is that SB was delivered by Dr. Sabrina Kuzma. So in terms of our optimization objective, actually, when we wrote our grant application, it was cost effectiveness, but the field really evolved over time as we were doing the study. And then we did do cost effectiveness analyses in the traditional sense, but we switched to um, a new method that I'm going to talk to you about, where you identify a value efficient combination or combinations of intervention components, taking into consideration cost. So that's considered like a cousin of cost effectiveness. I'm going to talk a lot about that today, so you'll get a sense of what that is. Our primary outcomes, viral suppression, and then secondary reductions in viral load, being well engaged in care, and then health related quality of life, which as things improve in our field is considered the fourth 95 goal. Um, and just as a reminder, the barriers to these outcomes are very serious and hard to change. Our eligibility criteria, age adult, they were adults, African American, or Latinx, they can participate in English or Spanish, poorly engaged in HIV care in the past year, and then detectable viral load by lab report. And our sample size is 512. I think it's important to know that optimization trials are powered at the same level of a two-arm RCT. So you see 5 components. It's not 5 randomized controlled trials. It uses efficient design, so it's powered at the level of a two-arm RCT. And people were recruited in the community from peer-to-peer methods. You know, they're not heavily engaged in HIV care settings. It'd be hard to find them there. So we tried um, to find them in the community through peers. It's not that easy, partly because, you know, there's barriers. The reasons people aren't taking medication reflect other challenges in their life. And there's also shame and stigma for not taking medication. And so it's challenging to find them, but it can be done. All right, so our design. If we had done a full factorial design with 5 components, it would have been 32 experimental conditions. And I actually think that would be a lot to manage with no protocol violations for this kind of study. For an online study or something like that, you could do it easily. But for this, I think it would be hard. So we used an efficient fractional factorial design where you empirically select combinations of components and reduces the number of experimental conditions to 16. So the advantages are easier to implement, but the disadvantage to fractional factorial is it's something called aliasing, which means you're not able to examine 3- and 4-way interactions. So we didn't hypothesize 3- and 4-way interactions. We probably didn't have the power to examine 3- and 4-way interactions, so that was not a problem for us. And so this is what the design looks like. So you can see everyone gets core in black. And then you can see in MI sessions, if you look this way, half do not get it and half do get it. So right now we're just going by component. Pre-adherence preparation, which is the SB, the skill building, half get it, half don't get it. Peer mentorship, half get it, half don't get it. Same as sport groups. And then for navigation, we felt navigation was really essential. Um, and so instead of it being off on, which these other ones are off on, you either get it or don't, we tested short navigation, which was 3 months, versus long navigation, which would help us understand more about dose of navigation. But we did assume that everyone would need it. So I hope you can see my cursor, but if not, you can imagine it. So that's by component. But then if you look along the bottom, here's our 16 experimental conditions. So our team gave them animal names. So one is bear. And actually they knew what each condition was, which was kind of amazing. So in bear, they get core And then they get long navigation. 16 was yak. You can see yak. They get all of them. And we've done some analyses about whether attendance or affects attendance or feasibility varies by intervention condition, because that 16 is a lot of intervention. And the answer is no. We do have good attendance and good feasibility across all the conditions. And most of the conditions they receive two or three um, components. And if you're thinking like, oh my God, I never would want to do this. This is so hard. It's actually not that different from a classical RCT where you still need to schedule people. You still need to know what they got and what they didn't get. So say they have groups and they have something else, you still need to know, did they go to their groups? You still need to know what the next thing is. So it's it's not that different from an RCT, and 16 conditions, I would say, is manageable. So here's our design. We screened them, did our blood draw. They got a baseline assessment, then randomization. They received their intervention components, and then they got assessed at 4 months, 8 months, and 12 months. Sometimes the intervention components did stretch into this assessment period, and we did a lot of qualitative work. I won't go into too much about who they are, but we should talk a little bit about who they are. They're long-term survivors, and that's sort of important to know. They've had long periods on medication. They've had long periods off medication. They know that they're okay if they're off medication, although I don't know if they really think about that they could be doing irreparable damage to their immune system by not being on medication. But they know that they feel okay. They don't feel that great generally. And that makes it a hard problem to change. Just sort of as an aside, human beings, we are not rational. We are predictably irrational. And doing things that are hard to prevent something that may or may not happen in the future, that's really hard for the human brain. I give credit to anyone who does that. And maybe we all do, because at this point, all of us have some chronic condition. But it's hard with the fear and the distrust and um, whatnot for people to do this. So they're mainly assigned male sex at birth, mainly African American, 60% sexual minorities. And the years since HIV diagnosis range from 0 to 30. So those people with the 30, they've seen a lot, and they've saw the bad old days of HIV medication where they know about the AZT trials. They remember where you had to take 29 pills and half of them had to be with food and half were not with food and half had to be refrigerated and half didn't. And it was really tough. And that actually does factor into a lot of people's thinking for the long-term survivors. And they do stop and start medication a lot. The median is 5, but the range is, up to 300 times. Sometimes they take it for 3 days and stop. And then the longest duration of sustained HIV medication is 18 months, which is not very long if you've had HIV for 30 years or an average 18 years. Most of them lived in poverty. If they weren't poor to begin with, HIV drove them down into poverty, partly because of the benefits system. And substance use is a big issue in their life, past or present. And the substance use stigma seems to stick to them, whether they're using substances or not. So now let's talk about the analytic strategy for the optimization phase. So there's 4 stages. We're going to talk mainly about the first 2. So the first one is, do the components work and do they interact? So we can look at 2-way interactions in our model. We can't look at 3- and 4-way. That is called the conclusion priority perspective. Then you take the results from the conclusion priority and you look and you ask the question, what combinations of components best meet the optimization objective? This is a decision perspective. And we use a method called DAVE that I'll tell you about. And then there's different ways to do it, but the way we think of it is what implementation issues influence what combinations you might put forward and or next steps. And then new for 2026, which we're not going to talk about today, but you can join the intervention optimization center here at NYU and learn about how we can optimize for equity. All right, so our conclusion priority results. My advice, don't worry too much about the details. It's mostly interactions. It's kind of hard to follow. But the conclusion priority results go into the Dave results, the decision results, which are not hard to follow. So just ride with me through this, and I'll do my best. Talking about interactions in a talk where I'm trying to do my best is not easy. I will do my best. Well, it's easy for some people, but it's not easy for me. Okay, so we had an antagonistic interaction effect. So first of all, remember I told you when I first heard that happen, I was like, that's not a thing. Well, it is a thing, as I mentioned. So this probability of viral suppression was highest when motivational interviewing or support groups was assigned, but not both. And you can see that the motivational interviewing gets close to 55% virally suppressed in this analysis. Now we're going to look at viral load, so lower is better. Short navigation, when short navigation was assigned, support groups decreased viral load. And then when long navigation was assigned, support groups had no effect on viral load. We had an interaction effect between skill building and peer mentorship, where the skill building component seemed to have a more favorable impact when the peer mentorship was assigned. And then we also looked at quality of life, the fourth 95 goal. And I think something that's going to be increasingly important as more and more people are virally suppressed. And we found that motivational interviewing sessions improved quality of life, or what's called health utility in this analysis, but the same thing. And then skill building component that Dr. Klusman administered also improved quality of life, the habit formation component. Okay, so what do we know? Some of the components do not play well with each other, antagonistic interactions. Some of the components need the other to be effective. And importantly, you would not know this in the classical approach. You really wouldn't. And like for us as interventionists, this is really cool to know and also think through like what that means and why. And help us understand intervention better, understand behavior change better. So I think that these learnings are really important. Okay, so let's go to decision, best combinations. So Dave was developed by Dr. Collins, Dr. Van Ness, and Dr. Strayhorn. Dr. Strayhorn is here at NYU, and it provides a value efficiency frontier. Now, the cool thing about Dave is that it can consider single outcomes like viral suppression or viral load reduction, but it can also look at multiple outcomes simultaneously. So in HIV, we are mainly interested in viral suppression, but I'm going to show you an analysis where we looked at different outcomes together, our primary and our second outcomes together. In some cases, it's very valuable to look at multiple outcomes simultaneously. And if you consider cost, the value efficiency frontier begins with the least expensive alternative and ends with the intervention that maximizes the value function. And the decision maker can work up or down the value efficiency frontier to decide which intervention offers the best balance of expected value and cost. And again, it's a cousin of cost effectiveness if you include cost. We've done optimization trials where we didn't have cost data. And in that case, you can look at time or some other factor. But cost is a good one, and it speaks to funders. All right, so here's our results on HIV viral load, which we use viral load because you do lose a lot of power if you dichotomize your outcome variable. And the green line shows the three combinations, was not a combination, on the efficient frontier. For the combinations that you could carry out for less than $1,500 a person. So we see that short navigation is pretty good. This is better, lower viral load as you go down here. Long navigation is good. And then the combination of motivational interviewing and long navigation sort of gives you the highest value efficiency beneath this threshold. And you can see up here that the other combinations were a little bit more expensive. Although we use the fractional factorial design, I do not know how, but they can actually plot all 32 combinations, even though we didn't have 32 experimental conditions. I will leave that to Dr. Collins to explain, but that's what they tell me. All right, so let's look at HIV care. That's really important. And we found that short navigation and then peer mentorship and short navigation together give you very high value efficiency, again, for that same threshold. And then we looked at quality of life and some similarities. So short navigation gives you some, and then you go all the way up here where you could do motivational interviewing, peer mentorship, and short navigation. And then up here, combinate, this is all of them together. With long navigation, you could see it's more expensive, so that gets knocked off. And then some other options down here. And then this is the big innovation for Dave. You can look at multiple outcomes weighted. You have to decide how to weight. Um, and we talked to some economists about this, but we weighted viral load heavily, quality of life second, and then care was third. So viral load is the main concern here. And there are two combinations that really stood out. One was skill building, support groups, and short navigation. And then the second was motivational interviewing and long navigation. Um, so then we can take this and we can start thinking about implementability. Um, so I think, let me see what this, for me, I think for most clinical settings, motivational interviewing and long navigation would be a lot easier to implement than this other one. Groups in particular are a lot of work. You know, everyone's schedules are different. You can do them virtually, but for the most part, they're done in person. And they not you don't always have the capacity. Not everyone's trained in groups, but most clinical settings have someone who could do motivational interviewing counseling and long navigation. So we can disseminate both of these versions of the multi-component intervention, but also we can emphasize or like point out that there's implementing differences in them. And again, our long navigation, so if you're thinking everyone does navigation, it's true they do. But just as a reminder, our navigation is a little different in that it's grounded in the ICM, and we don't assume that people are ready to take medication and whatnot. We support autonomy, and it is also grounded in some other factors. For example, knowing that substance use is chronic and recurring, and not assuming that just because they've been told not to use substances with antiretroviral therapy, that they're not. Okay, so that's our findings to date, and now we get to potential next steps. So we have choices in the framework. We can go to an evaluation RCT. We could go back to preparation. We could go back to an optimization trial. So overall in the study, 40% of the population or of the sample achieved viral suppression. We've done 3 optimization trials with this population not taking medication. We did a small one, a medium one, and a big one. In the small one, 40% achieve viral suppression. In the medium one, 40% achieve viral suppression. And in the big one, 40% achieve viral suppression. I think we can do better, actually. 40% is not nothing. It's good. It's a hard thing for people to do, but I think that we can do better. I personally think that doing a 5-year evaluation trial or a 4-year evaluation trial is not always necessary in the framework because you have a ton of information about your intervention from the optimization trial. It's not tested against a control. There's no control in the factorial design, but you do have a ton of information about the intervention components from the optimization trial. So, all right, so one thing we can do is disseminate. I don't have a lot of enthusiasm for doing the evaluation trial, but what I think would be interesting is shifting to another design. So in the factorial experiment, and in most of our interventions, we create something called a fixed intervention. You get the intervention. Either it helps you or it doesn't. There's nothing more. That is, most interventions are like that. Um, you hope it's effective enough to be worth it, at sort of the population level or the sample level. But in clinical work, whether it's medical or psychotherapeutic, that's not what you do. So someone comes in, you do your intervention, it doesn't work. You don't say, well, goodbye, that's it. You try something different. So, in response to that idea, there's a whole field of adaptive interventions, which components are introduced or taken away depending on how you respond. And to create a good adaptive intervention, you can use the sequential multiple assignment randomized trial, or SMART. You might notice that actually Linda Center, they're very good on acronyms, or they spend a lot of time on their acronyms. So this is what we're thinking about doing next, which is to sort of look across our complicated findings and sort of look for what the signal is. So one signal is like the habit formation component is really powerful for people. And then also navigation is really powerful, but people need different things. So in this design, you'd start with habits, and then at a certain point, you would assess their viral load. If they've responded, which means they've achieved HIV viral load, you can randomize them again. You can either stop the component or you can taper it, and that'll answer questions about the best way to do this. If they didn't respond, you can randomize them to be augmented with navigation and still get the skill building, or switch to navigation. And then in this other pathway, you start with navigation at 3 months, again, a low dose, to see if they've responded. If not, you could continue with navigation for 6 more months or switch. And then again, if they responded, you can stop or you can taper. So we've been working on this, but may you live in interesting times. I'd say for the last year, we've been sort of waiting to see what NIH's HIV priorities are. And I would say now we know. NIH is interested in HIV research. And they're primarily interested in implementation science. But the good news is the most framework really is a type of implementation science framework. First of all, you can test implementation science components in the framework, but also you have implementability from the outset, which is consistent with implementation science. And you could have a combination of components, implementation science components directed at providers or settings, and also at individuals. So I haven't been ready to do this next step, but now I am definitely more ready. If you're thinking that's interesting, it's fine. I do the classical approach. I can't do this. Well, that's what I said. Actually, I had cold feet when I first started talking to Linda Collins about doing this study, and we're now seeing cold feet is common. But if I can do it, you can do it. And the good news is that there's a lot of resources now if you're interested in exploring the framework. Linda Collins's moonshot goal is to have intervention optimization be the way that we create interventions and develop interventions by the year 2030. NIH has funded 300 to 400 optimization trials at this point. So it's even like, we don't even go on about how innovative at this point, because it's not even considered that innovative, but it does have a lot of utility. So there's a center at NYU, it's called CADIO, which you can join. They have talks, really interesting talks on Fridays. And there's a Coursera course. It's actually free unless you want the certificate. And if you want the certificate, it's $50. And then they also have hybrid trainings once or twice a year. Um, and then there's the first conference on intervention optimization in May in Bethesda that you can attend. I'm going. I'm really excited to learn from the experts because as much as I know about intervention optimization, it is such a fascinating field. And like every time I've had like a methodological problem, it's like you can't do it. Like peer, you can't integrate like peer education into it. You know, Linda has ideas like just so fantastic. And you get consultation from the center too. So I invite you to come to the conference. And if you want my slides, talk to Chris and you can get the link to the conference. So that's all for today. And I'm happy to take questions. Here's our team. And I just want to thank you so much for inviting me and for your time.